So good morning, everybody. I hope everybody's doing very well today on a Friday. So before I begin, let me just introduce myself. My name is Jonathan Ong, and I'm the Senior Health Manager for the Informatics Program for Mecklenburg County Health Department. And then Frank.
Hi, my name is Frank Diaz-Garelli. I'm an assistant professor of health informatics at UNC Charlotte. Work closely with Jonathan Ong, and very excited to be here.
Thank you very much, Frank. Let me just start my screen sharing, and then we'll begin from there, okay? Very good. Thank you very much. So just before we begin with the presentation, we'd just like to remind everybody that this is a very interactive session. And the charge for us at the end of this particular session is to really come up with ideas, and just like what Dr. Michael had said earlier, to innovate and think outside of the box, right? So for us to create a brief and bulleted set of priorities, strategies, and need recommended to address the underlying social determinant and structural behavior barrier. So what we plan on doing, Frank and I, is that we're going to have a couple of breakout sessions throughout the presentation, so that we'll be able to come up with the recommendations that answers the three Ps. So, and this will talk about the people, the process, and the product. And as we put things into perspective, we'll be able to have these different breakout sessions that will address these different things. So if there's no questions, and Teresa, you think we are ready to begin, I'll start off with the presentation. Okay, so I'm going to start off with a quote here by Dr. Karen B. DeSalvo, who really pioneered Public Health 3.0, where she said that Public Health 3.0 recognizes that we need to focus on the social determinants of health in order to create lasting improvements for the health of everyone in America. And I think that's really one of the main goals of our discussions today throughout this particular APHINexus. And that really what drives us in terms of understanding what we need to do with regard to Public Health 3.0. But when we talk about social determinants of health, and just a quick review of what that is, what does Public Health 3.0 really ask us to do? Public Health 3.0 calls us to boldly expand public health to address all aspects of life that promote health and well-being. That includes economic development, education, transportation, food, environment, housing, and safe neighborhoods. And what you also see here on this particular slide are the essential public health services that we need to be able to provide. But the biggest question there is that, so how? And so we know what it is, but how do we achieve that? So in the guidelines and framework of Public Health 3.0, there are three key themes that we need to understand. Number one is strong leadership and workforce, strategic partnership, flexible and sustainable funding, timely and locally relevant data metrics and analytics, and the foundational infrastructure that needs to happen within Public Health 3.0. So within this 5 different key themes, let me just give you a few examples of what has happened over the past 12 months here Mecklenburg County in terms of how we have addressed and met Public Health 3.0. So I'm going to start off with back in July, when the CDC director, former director, Dr. Robert Redfield, visited Mecklenburg County Health Department. A lot of these key themes were basically reinvestigated and rejuvenated because of the response that we had for COVID. So what we need to address here is that, one is that there's strong leadership and workforce. And if you have not seen the news, or if you have not seen any news briefings, you will not be amiss of Gibby Harris being on the news, making sure that everybody is informed of what's going on. And that strong leadership within public health right now is what we have seen under Gibby's leadership. And then the next bullet point here is strategic partnership. The COVID response from Mecklenburg County is not done just by public health doing it all alone. We had strong partnership, and we were in constant communication with the big hospital systems, with community organizations, and so forth. And of course, flexible and sustainable funding, which we'll discuss later on in terms of where we are with that. But there were funding that was made available to us that made a lot of things workable for our response. And of course, the biggest piece here is the timely and locally relevant data, metrics, and analytics. Gibi did mention during her opening remarks about how important data is, but of course, data is just data if nobody puts action into it. So um, relevant data is very, very important. And of course, the foundational infrastructure, which I believe here in Mecklenburg County we have established over the past couple of years. So with that short overview of Public Health 3.0, I think depending on the number of people that we have joining us today, what we would want to do is do a quick breakout session and address the question of what does Public Health 3.0 really mean to you? Have you used any of these components? What is it that makes your job easier? And do you see any barriers to implementing this particular vision? So Teresa, if you don't mind letting us know how many we have on this breakout session, and we could have them break out and do a discussion on this. And what we're hoping to get from each group is that if a group would volunteer, if this particular topic strikes you, is to volunteer out so that we could put that into our report out session for this afternoon. So Teresa, do we know how many people are or have joined us?
Yes, not including me, there will be 18 participants.
Okay, so should we break out into two groups and then have the discussion within those two groups in terms of these questions? Okay, so I think we could continue. And so maybe we'll start off with Frank, your group, to give us a quick report out on this.
Yeah, I'm happy to do it. We had a lot of good feedback from many different perspectives. And basically, the take home message was that people thought that the Public Health 3.0 was a really valuable way of approaching public health. We even discussed a little bit about how it can interface with clinical care, particularly in cancer. We talked a little bit about the dashboards and how they can help turn data into actionable information and support public health and also clinical work. Some of the barriers that were mentioned had to do with systems not being in tune with the current workflows and being more of a hindrance than a help to people's jobs, and we completely understand that. We also talked a little bit about what can be done to mitigate those things, but overall, it seems like the vision of healthcare 3.0 and using a data-driven approach to public health to support both community work as well as clinical work was seen as something positive and valuable.
Thank you very much, Frank. So for our group, and if anybody wants from my group to report out, but let me report it out for them. One of the things that I did share with the group that caught my attention was the one that was shared by Kieran from the EPI team from Mecklenburg County, was that fact that hearing about Public Health 3.0, she now realizes that it's now in a broader field of public health. It's not just about the social workers trying to identify social determinants. It's not just about the epidemiologists trying to figure out where things are happening, but really across all of public health, which is really good to hear. And we did get some feedback in terms of how Public Health 3.0 is affecting everybody's work. One example was from Dr. Hani Abaful, who does pediatric dentistry here at Mecklenburg County, that they don't just treat the patient, they treat the whole patient by making sure that they're addressing nutrition, they're providing educational support, and they're also actually doing following up on their patients with regards to vaccination, which is something that I didn't know. And that's a really good thing because now they're opening up the services of what they do to address that vision of Public Health 3.0 of addressing all the other social determinants of health as well. So that's what was shared within our group. So I think that was really good input. So to continue on the discussion, now that we understand what the vision is of Public Health 3.0, we're going to go now next to what it is for Mecklenburg County Health Department and what the Public Health 3.0 has happened here at Mecklenburg County. one of the things that I would like to point out that is that this particular slide is just a summary of what has happened and are taking in shape as what we're experiencing here in Mecklenburg County. And as we know, over the past 12 months, we've been interrupted by this so-called virus called the coronavirus. So a lot of the work that we're doing has actually been put on hold. But one thing that I would like to point out is that here in Mecklenburg County, during this pandemic time, we've actually highlighted all of these needs and all the work that we've actually put in to address public health 3.0. So one of that is infrastructure. We now have data lakes, data dictionaries, and we now have data stewards that actually understand what the data is within our system. One of the other things that we have addressed within Mecklenburg County is skill building. One of the things that we did address over the past 3 years now is that we are starting to optimize systems, and not only we're optimizing systems for the clinical piece, but we're optimizing systems for all kinds of services, including environmental health, our communicable diseases group, and so forth. The biggest piece that we are working on is on data governance. And one of the things that we did work on with APHI the past year was the data across sectors of health, which provides us with a foundation of what data governance is. So we now have an idea of what data quality means for Mecklenburg County. We now have some analytics that we're able to draw out from all of this data. And of course, the biggest piece that I would like to point out is data sharing. We now have a stronger data sharing platform that will be able to share data and take data from organizations outside of the health department. And of course, in the next coming months within Mecklenburg County, we are actually moving towards staff development, where we're actually providing more of leadership training, staff engagement, to make sure that how we understand public health 3.0 is how we also bring it up to the staff who's actually going to implement this kind of things. So this is just a slide that I just want to share with everybody, which I think summarizes what it means to have that Mecklenburg County approach to public health 3.0. One is that Mecklenburg County has been a key strategist in a lot of the response that we've had over the past 12 months, right? And that's one of the main highlights of public health 3.0 is for the local health department to be the key chief strategist in terms of how we approach the things that need to be accomplished within public health. The other things that we have actually that this particular slides almost sort of like addresses is that we have developed key infrastructures that allows us to develop systems to help with the response. Mecklenburg County IT has done a tremendous effort to make sure that we have been provided with the infrastructure, with the equipment to be able to address as soon as the pandemic hit. And we're able to actually develop systems that will actually gather data with our COVID investigation, with our COVID hotline, with even with our vaccinations response. So we've done a huge bit on infrastructure the past 12 months. But even before that, we have started developing data lakes and data dictionaries that provides us with access to data, so that we'll be able to not only keep the data, but also take data out for analytics. The other key components of Public Health 3.0 that's been highlighted here in Mecklenburg County are the partnership. We have partnered with Novant, with Atrium, with a lot of community organizations, including faith-based organizations. We have partnered with StarMed for our vaccination administration support. So a lot of this partnership help us deliver all the services that we need, not only for the clinical response, but for all the other responses through social workers and so forth. One of the biggest key things that I think was highlighted in today's opening remarks were about data. In one of the keynote presentations, they did speak about the 3 principles of action driven, and one of that is making sure that we have access to data. And of course, the last one here is on Public Health 3.0 that's been very much highlighted within Mecklenburg County is sustainable funding. back in July, when Dr. Redfield, the CDC director, came to visit Mecklenburg County Health Department and looked at how we were able to address our COVID investigations and how we're able to address and take care of the community as a whole. One of the things that were highlighted during the conversation was that not only did we have great access to data, but having that information flow down from federal to the state that includes sustainable funding. One of the key recommendations that was presented to Dr. Redfield was the fact that we need to have funding not only for during pandemic, when the pandemic happened or when a disaster happened, but funding that will be ongoing so that we don't simply create something because there's a need for it, but we are creating something in preparation for all of these different scenarios. So I think this particular slide addresses it all when it comes to process, funding, infrastructure, and the partnership we have with the different organizations. So I guess for our next breakout session, these are the questions that we would like to pose to everybody. What kind of work are you involved in this? Are you part of a team that or a collaborator, or you are part of a partner institution with Mecklenburg County? Have all of these things that Mecklenburg County put in place have made your job easier, harder, or maybe not so much? And of course, this is where we'd want to really get your ideas in terms of suggestions for your future projects for Mecklenburg County, in terms of what we would like to focus on and what we'd like to see as a response for us to be able to meet our Public Health 3.0 goals and objectives. So, okay, I think we have everybody back in the main room. I guess for this next reporting out session for this particular segment, I'll start off. Dr. Frank, if you don't mind.
Yeah, sure. We had a lot of really good conversation, but one of the things that came out is that it's hard for people outside the department to see if they're using data integration, which is exactly kind of the way we want it. We want encapsulation, so you guys don't have to worry about all the bells and whistles that go into integrating data. It's really complex work, and the least you notice what's happening in the background, the better we're doing our job, or Jonathan's doing his job, because we want something that works without you having to even think about it. But that being said, we did go into more details for a specific case where data integration and integration of systems would be helpful. We talked a little bit about the pediatric dentistry clinic that Jonathan had mentioned before. And one of the problems that would really be helpful in terms of data integration to support Public Health 3.0 would be to create systems that both allow clinicians to pull information from other systems to understand the whole context of the patient in the context of their area of living and distribution of public health. But also there was a particular problem with child abuse reporting and child neglect reporting, and having automated systems that would report things in the patient's chart and send it to the right parties would be really helpful and relieve a lot of additional burden placed on the clinicians for reporting. Also, there was a theme of documentation and being able to pull that data directly from the clinical documentation would allow it to provide a lot more detail to the parties taking care of those issues downstream. So I thought that was a really great suggestion for future work, and also the fact that it's coming from a dental clinic side of things that are not always integrated into the whole health side of things, but are an integral part of it. I thought that was a really great example for future work.
Yeah, that sounds really interesting. I mean, I'm very thankful to have Dr. Hani on today's sessions for those examples. From our group, there's a few people who are actively working on certain projects that could look into, as it's a public health 3.0 objective. A few are working within the county on a health collaborative that actually pulls in data from different services, not just health, but other health services, health and human services within the county. So we have that health collaborative that people are working on. And there are also individuals who are in support mode with regards to assisting the different services to meet Public Health 3.0 within Mecklenburg County. Some examples that were also provided was the fact that over the past few years within Mecklenburg County, there's been a lot of in terms of making sure that we meet accreditation requirements, making sure that we not only achieve the metrics that we've set up, but translate that into changes and to actually funding that will help promote these changes as well. And a few of the ideas that came up during the conversation in terms of how we could move this more to a broader audience is to have a maybe a combined town hall for APHI and public health on a more regular basis. Mecklenburg County Health Department typically does a town hall with Dr. Salvin and Dr. Raynard Washington to discuss changes in our response to, let's say, the COVID um, testing before. Now we're doing COVID vaccination. So there's been town hall regularly to give everybody an update on what that means. But I think with that engaged population right now, one of the recommendations is now to move that to a more so what are our plans for our next issue that might come, or maybe have APHI and public health to address a social determinant or a health issue of the day to keep people more engaged with this particular work. Um, and then the other piece that they want, let me see, I think that's pretty much it in terms of project ideas. Um, yep. But yeah, I'd just like to point out that the Mecklenburg County is in current works right now to create that single view of an individual through our human health services collaboration to create that aggregation of data for that person that we're serving. So hopefully this will become available for our dental partners so that they'll be able to see the bigger picture of that individual. And I just want to point out that one of the things that we're working for Mecklenburg County this year is the fact that we are connecting with the state health information exchange, which is the state HIE. In that way, we're able to see not only Mecklenburg County data, but data from all other healthcare systems that's contributing data to the state HIE. So hopefully in the next couple of months, we'll be able to have that and have our participants in Mecklenburg County be able to view not just their current medical records within our system, but also records and notes and everything else from other organizations throughout the state of North Carolina. So that's something that we are looking forward to bring data back to our practitioners. So thank you very much. So I guess we're ready for our next part of our presentation. I'm gonna turn this over to Dr. Frank for the response of UNCC, Public Health 3.0.
Thanks, Jonathan. So basically what I wanted to do with this part of the presentation is to give you a little bit of an understanding of what we're doing at UNC Charlotte to support the Meg County's health department efforts to bring about health, public health 3.0. APHI is its integral mission is about building healthcare 3.0 in the Mecklenburg County. The idea is to strengthen cooperation, coordination, exchange of resources to help this come about. The idea of having innovation in APHI is because building public health 3.0 is going to require a lot more than resources and using the same tools that we've always done. So what we try to do at APHI is bring people together so we can think outside the box and build this ideal of public health that goes way beyond what we've seen before. For those who have a public health background, you remember the example of using plotting data to geographically to understand the distribution of a disease, to understand where the source is. Well, that was innovation at the time, because nobody had ever done it. So what we're trying to do with these meetings and everything we do at AFI is trying to find the new ways that are going to unlock us to build systems that will allow us to take care of people at the community level. So the mission of AFI is to develop solutions to address Charlotte's area's most pressing community health needs. And the way we do that is doing three or four things, out of which I picked three. Um, so supporting implementation of evidence-based community health practices, uh, com- coordinating training programs and professional education, and expanding the ability to systematically collect, analyze, and interpret health related data. The subtext here is that most of what we do at AFI is data related. If it's not data driven, it's data supported. And if it's not neither of those two, which is really rare, it's going to be evaluated through data. If we go to the next slide and look at a screenshot of the AFI project page, we have the four top projects that we have here are data driven, and here's why. The HIV prevention efforts that we're doing are based on tracking and monitoring of data that describe the patients, and a lot of what we're doing is trying to do surveillance of outbreaks that are based on data and creating dashboards that are meant to turn raw data into actionable insights. If we look at the effort that is geared toward integrating data across sectors of health, uh, that's basically using integrating data so we can see more through what we already have. Building uplifted family is also a data driven effort, as it slide. So that one is not necessarily data driven. That one uh, is more supported by data through the development and through its evaluation. And the healthcare hackathon is basically a bunch of people from Charlotte and the Mecklenburg area looking at solving data problems to enable healthcare. So this is just a reminder of what we're doing at the UNC side, but showing you how data is important. And this is just a primer for us to start thinking of how we can make this data orientation a little bit more natural to all of us, even if your job, especially if your job is not about data. We really need to get people who are out in the community and people who are clinically oriented to at least understand what their information needs, so the data people can support those things and help you do your job even better by having better information. So Jonathan, I think you've got the next slide.
So this one is about so this particular slide now talks about that data driven is not just all about technology. And I don't know if Dr. Frank, you have some thoughts on this with regards to what this actually means to us. And I think this is one of the things that we would like to have a bigger discussion during the breakout, is that
Absolutely, yeah.
is a discussion about being data driven, and the culture of being data driven is not just all about
So
technology, the high
I,
tech stuff,
I,
right?
I do have a few examples because this is part of what I teach, but data has so here's the thing that a lot of people may not realize. Data has nothing to do with technology. I mean, if you consider pen and paper technology, sure, it's always technology driven, but the idea is that data is just raw information or pre-information. It's just basically accounting for what's happening out in the world. And it doesn't have to be based on a smartphone. It doesn't have to be based on a database. Uh, Actually, paper records are a great source of data in the clinical setting. And that doesn't really require much technology. Of course, if you have a million patient records, you need to have a system uh, to keep that information organized. However, it's not something that people would consider low tech. Being data driven on the flip side is making sure that you're recording what's happening, so you know what happened in the past, so you can study it and make better decisions in the future. So what we're trying to get at when it comes to data driven, it's more of the idea of making sure that we're recording what's happening so we can both look back and see what happened and look forward and evaluate how we're doing. Does that kind of go in the direction you were thinking, Jonathan?
Yeah, that's correct, Dr. Diaz. So with data driven, one of the things that I mean, here, especially in Mecklenburg County for the informatics team, is that data driven is not just all about the bells and whistles of a high tech new equipment that we could have, but it's really more about the the way of how we think about how we're doing our work. Are we able to capture data as we're doing the work so that we'll be able to report that out? Yes, pen and paper is a great source of data, but in today's time, we need to also think about how we can easily share that data to people, how we can easily analyze that data. And sometimes it's not about the fancy, the databases and all these different things that most of you might not really understand, but it's really about the thinking of, are we capturing data? Are we saving it so that we'll be able to extract data later on for future use? So one example of that will be, for example, for our COVID investigation. Initially, we did not have any cases here in Mecklenburg County, but we know that potentially it could go through a process where at the end of the day, we know that we need the data to be able to analyze what our next steps would be. We know that public, the media, wants to hear what our data is. We know that even for Mecklenburg County Health Department, our commissioners need to have data so that they'll be able to help provide guidance with how they're making decisions. So whenever we're thinking of what we're doing, we're also thinking about how we're capturing the data as we go along. So the question that we would like to pose to everybody during the next breakout session is that, so one is that, what does data driven really mean to you? Okay, and then maybe if you could come up with some examples of a data driven project that considered without high tech, right? One of the things that I remember when Dr. Frank and I were discussing this presentation was the fact that a lot of the students right now are all about, I need to learn Python, I need to learn the next new type of software out there. But sometimes it's not about learning these new programming languages, but really seeing how we can apply the data um, to our daily work, right? It sometimes we come in and say, you know what, let's apply a Python regression and all these different epi and epi terms that you have, but at the end of the day, you might need to just simply find out what's your ratio, right? As simple as that, to figure out where the differences lie. So, and that's what we would like to post to the group, is that, what does data driven mean to you? And I guess to further expand on what being data driven is about, we have this sort of like questions about what we would like for you guys to identify, is that, are there any gaps and needs of current public health practitioners that for us to be able to meet the challenge of public health 3.0? And for our academic counterparts, what are the current roadblocks that you think would help you prepare students for the real world of public health? So a few of the resources that we have come across, we have shared under our resources slide. But for this next breakout session, what we would like to do is to answer these questions in terms of, what do you think are the current gaps in public health right now? And what are the roadblocks for our academic counterparts that will help prepare them for the real world of public health? Okay, I think everybody's back. I know that there are some people who had to leave a little bit early for another meeting, but I think let's just wrap up with that breakout session with the reporting. Let me start off from my side. One of the things that I guess one of the recommendations that we have is really to start training staff, not on the high level overview of 3.0, so that it is really emphasized, not only from a leadership perspective, but from the grassroots level. And then one of the things that that was for me was very profound was when Dr. Hani had shared with us that we need to start gathering data from let's say from dental, right, to help provide services for other clinics. One of the things that I told Dr. Hani that I'll be stealing from him is that we're not just treating the teeth in humans, but the humans with teeth, and this could be applied to all in all clinical aspects in all of the services that we do with public health. Right, we're not just treating STD in humans, but we're treating the human being and not that have the STD, for example. Or we're helping out we're not helping out provide food that the human needs, but just the human being itself. So I think one of the things that were shared earlier was the fact that there are some um, concerns too, that there are some individuals who don't like to get these services because they feel that they are getting handouts. But they need to understand that these are not handouts, but usually a helping hand to get them on so that they could become better to where they are in their particular state. So those are the different examples that were given during our breakout. And one other thing that was shared with us was the fact that providing in services and learning on how to access data and how to use this data. Because I think one of the things that we have come across was the fact that there are some people who keep data to themselves and that's it, and doesn't get shared across. So I think doing an in-service learning in terms of how to access the data, where the data is, and how to use this data will be very beneficial for the different groups. So I think that's from the public health side, and then from the academic side, Gary, who's an alumni of UNCC for the informatics program, did say that there should be some form of training to help translate high-level data to more consumable information, because we know that you don't need to provide them with what's your R when you're talking to your commissioners, right? What they want to know is that what's that data that I need so that I could make proper decision making, staffing plans, and so forth. So having that type of training for our academic counterpart will be very, very helpful. Dr. Frank?
So from our end, we had a very similar comment and suggestion to what you were saying with training the frontline workers, but it was more on the angle of empowerment and showing them that the work of entering data is actually valued and used downstream. The suggestion was to create orientation slash training sessions to make them understand how the system works and how the data that they entered is being used downstream to support public health 3.0 initiatives, and also help them understand why we are asking the things that we're asking so they can educate the patients so they understand that we're not trying to spy on you. What we're trying to do is to improve health, and there's a very clear usage of your data downstream. So I thought that was very insightful, and would allow for the engagement of frontline workers and a better relationship between the people in the back end with the data and the informatics side, and also the frontline workers that know how that data is being generated. I thought that was a really great suggestion. Another barrier that was mentioned was access to data and education. So on one hand, it was access to the data to understand what's available and what's in there. But another very, very insightful suggestion was providing access to analyses that's been done on the data and prior results to understand what's been done to inform future analyses that could inform downstream work to support healthcare, public health 3.0. So there were multiple suggestions to address this, but access to data models and how to find data was one. Providing open results in the form of either a website or even a Twitter feed, so everybody's aware of what's being done with the public health 3.0 data and what's been found out. Those were really great suggestions to get people more involved and build that culture of data that we've talked about before.
Thank you very much, Dr. Frank. So, I mean, from all the breakout sessions that we've had, I think we've gathered really very insightful information and feedback from everybody. Just looking at the chat, there are some questions with regards to how to get more involved in APHI. I think we have the contact for Dr. Michael Thompson, who will be able to provide you with more information about that. Um, and we just want to point out that there's a comment about here about the challenges that we have is that there's a challenge in collecting data when the client is hesitant to share any personal information. So many senior citizens are scared to share personal information because of identity theft, scams, etc. And that's something that we in public health are very much aware of, because a lot of the things that we do involve getting data from our clients, and sometimes it's very difficult to make sure that we have good data for that. So but yeah, thank you very much for all your insights, and hopefully what we will plan on doing is to put all of this information together, and we'll have our 2 p.m. Report out and synthesis session, and then followed by the panel discussion and closing remarks. So Dr. Diaz, before we end, do you want to give anybody your closing remarks for this?
Yeah, so I want to thank everyone for all this wonderful feedback that you've provided. There is no way that we can know all this stuff because we just one little piece of the puzzle here, and we're really grateful that you're taking time out of your day to join us and tell us all about this. Again, we are really driven by serving you guys and helping you do your job better. So we're really, really grateful that you're taking the time to tell us how we can do things better. Thank you very much.
Thank you very much, Dr. Frank. And without repeating what he said, thank you for the time that you've spent with us this morning. And we're hoping that we'll be able to really put all your insights for our synthesis session this afternoon. So you guys have our information, and hopefully if you want to touch base after this, please do reach out. We'll be happy to continue the discussion after this event. Thank you very much, everybody.
Thank you.